Hello, good evening, everyone, and welcome to the EUROGEN webinar series. I'm Michelle Batty, and I'm the manager of the EUROGEN network. So what is EUROGEN? Well, in 2017, the European Commission created 24 networks to deal with rare diseases and complex conditions in order to bring all the scattered knowledge around Europe together and really create an ecosystem that can really improve the lives of patients with rare diseases. And our network, EUROGEN, which deals with rare urorectogenital diseases and complex conditions, is currently 57 healthcare providers in 20 member states. So we're all working together to share expertise. Tonight, I just want to focus on one of our activities. So we have the IT to be able to do virtual cross-border consultations. And it's a highly secure system provided to the 24 ERNs by the European Commission. It's recently been updated by IBM. Now, we're very excited about this. So, if anyone listening out there has a complex or tricky case and you'd like, well, any advice at all, really, it could be about diagnosis, treatment options, any aspect at all of the surgical procedure, we'd be delighted to help. It would take about half an hour. We would guide you through using the system. Then you upload the medical data and we can arrange a meeting with some of the people in our network who have experience of these complex surgeries. So I do encourage a few of you out there to test this with us. We'd be delighted, and we can be contacted through our website. Other activities are training and education activities like this webinar program, and also we have a EUROGEN registry, which is very important as we hope that it will help provide the evidence in the future for our clinical guidelines and for future research. Okay then, so tonight we're going to be talking about urological aspects in pediatric kidney transplantation, with a real focus on multidisciplinary evaluation and management. So really, it's going to look at all the critical aspects of urology in the context of kidney transplantation. There'll be a detailed overview of pre-transplant evaluation with a special emphasis on patients with known uropathy. And then they're going to explore key intraoperative considerations that impact surgical outcomes. The session's going to cover urological complications, discussing their epidemiology, clinical presentation, and management strategies. So it's a great honour to have with us this evening the team from Padova in Italy, who are, of course, one of our members. And we have Professor Alessandro Morlacco, who is a paediatric urologist, Dr. Elisa Benetti, who is paediatric nephrologist, and Dr. Maria Sangermano, who is pediatric nephrologist, and Dr. Federica De Corti, who is a pediatric surgeon. And this webinar is eligible for EACME accreditation points, and it's supported by ESPU. So thank you very much to everyone here for sharing their expertise here with us, and I will give the team the floor. Thank you.
Okay, good afternoon, everybody. Thank you for joining us. I'm Alessandro Morlacco from Padova University, working here as a pediatric urology. I want to introduce my co-presenters. It's really an honor and a pleasure to be here. We have Dr. Elisa Benetti and Dr. Maria Sangermano, who are both pediatric nephrologists working very closely on pediatric kidney transplantation in clinical and also in research aspects. And then we have Dr. Federica De Corti, who is a pediatric surgeon, and she is really involved in the technical aspect of pediatric kidney transplantation. So I leave first the part to the pediatric nephrologist. We have no conflict of interest, and we can start.
Okay, thank you. Good afternoon, everybody, or good morning, everybody. Let's start with the pre-transplant urological assessment. Just as we know that transplantation is the treatment of choice for children with end-stage renal disease, we are all aware that a graft doesn't last a lifetime and that many children will require more than one transplantation. The early identification of factors that can impact on the graft function is important to improve graft survival, and urological complications are certainly among these risk factors. A tailored urological pre-transplant evaluation is therefore essential to guide individualized interventions and to optimize graft long-term outcomes. The pre-transplant evaluation should address several key aspects. First, the cause of end-stage renal disease must be identified if possible, determining whether it is nephrological or urological, and or both, and whether it is congenital or acquired. Second, early identification of urological risk factor allow to implement preventive strategies. In this regard, bladder function must be carefully assessed to ensure an adequate volume and function after transplantation. Third, native nephrectomy may be considered pre-transplantation in selected cases to reduce the risk of urological or surgical complications. Finally, in cases of small recipients receiving the graft from a larger donor, such as in living related transplantation, needs to have a clear plan for vascular and urinary continuity, taking into account the potential coexistence of other abdominal devices. Several studies on pre-transplant urological assessment are available in the literature, and they all agree that ultrasound of the kidney and the urinary tract with post-void residual bladder volume measurement is the basic investigation and should be obtained in all candidates for transplantation. It is a simple exam that provides very useful information about the urinary tract and allow to detect abnormalities that may require for further investigations or for pre-transplant surgical management. Following ultrasound, a very useful investigation to detect anatomical abnormalities is micturating cysto-urethrogram. MCUG is not a routine analysis and is reserved for selected cases to evaluate or exclude obstruction or significant reflux in children with known or suspected congenital anomalies of the kidney and the urinary tract involving the urethra or the bladder outlet, in those with lower urinary tract dysfunction with high post-void residual or abnormal uroflow, and in children with a history of prior urological surgery. Video urodynamic study may also play a key role in the pre-transplant evaluation of selected cases, in particular children with the lower urinary tract dysfunction. VUD allows to assess bladder safety before transplantation and to identify hostile bladders with low compliance or high pressure and to plan the appropriate medical management or reconstructive procedure when needed. Studying bladder function is crucial to protect the graft. In fact, a key concept is that the same bladder dysfunction that caused or contributed to end-stage renal disease can also seriously jeopardize graft function if not addressed. So this is a very important point to take into account. Another investigation that is often complementary to ultrasound and previously mentioned studies is urethrocystoscopy. It is not a routine test, but is performed only in selected cases, in particular children with congenital obstructive anomalies such as posterior urethra valves, or in children with previous urological surgery. It helps to define in the anatomy of urethra and the bladder, to assess scarring or residual obstruction in case of previous urological interventions, and to support the planning of bladder reconstruction on augmentation if needed. In addition to the aforementioned assessment, preparation for transplantation may also include the management of low urinary tract dysfunctions, as previously mentioned, through medical therapy, measures such as clean intermittent catheterization or bladder recycling, or bladder reconstruction or augmentation. The selection of the most appropriate ureteral implantation technique to reduce post-intervention, post-transplantation complications, and the planning of native nephrectomy if indicated for nephrological or urological or surgical reasons. I would like to underline that the timing of these interventions is crucial. In fact, both urological or kidney surgery must be carefully planned, as inadequate timing may worsen chronic kidney disease or may even compromise graft function. In summary, pre-transplant urological evaluation encompasses a wide range of aspects that are not only exclusively urological or surgical, but it goes beyond the anatomy and function of the bladder and the urinary tract and involves nephrological and general issues such as fluid balance, urine output, or residual kidney function. Therefore, close collaboration within a multidisciplinary team is essential to review investigations, to identify additional diagnostic needs, to define the best strategy for transplantation, and to plan corrective or preventive interventions in order to optimize the graft long-term outcome and to ensure patient safety.
So, my turn. As we have seen, an abnormal bladder is not a contraindication to transplantation, but the preparation before operation is fundamental in order to obtain a low-pressure, high-capacity reservoir with good drainage. And in case of doubt, remember always that graft safety comes first. The surgical approach for kidney transplantation might be extraperitoneal or intraperitoneal. In our center, we use the extraperitoneal approach even in small children because it allows an optimal exposure of iliac vessels, but in our experience, a good exposure of aorta and vena cava, even in small children when necessary for anastomosis. And moreover, peritoneum is left free for subsequent peritoneal dialysis when necessary. In some other centers, intraperitoneal approach is described for an easy access to aorta and vena cava, important in small patients, and for a less complicating closure of the abdominal wall, especially where donor mismatch with recipient is high. The intraperitoneal approach, nonetheless, exposes the patient for possible twisting of the renal graft and possible bowel lesions and obstructive syndrome in the postoperative period. Vascular anastomosis are made in an enterocyte fashion with non-absorbable stitches, and sometimes complex bench surgery is necessary to reduce the number of the vascular anastomosis in the patient. So in presence of more than one artery or more than one vein, a complex bench surgery is needed sometimes to reduce the intraoperative, the warm ischemia time at the moment of transplantation. Patients in pediatric age who underwent to a kidney transplantation can present complicated bladders and significant intraoperative challenges. We can face small or fibrotic bladders with a reduced functional capacity and poor compliance. And in these cases, one of the main intraoperative risks is to have a bladder rupture just when with the initial filling or distension. Sometimes we can face disused bladders, maybe after prolonged anuria, and in these cases, the walls can be small, the bladder can be small with thick walls, but often they recover capacity. In this case, an intraoperative strategy can be to obtain a gentle, controlled filling of the bladder to assess compliance and identify occult rupture sites before the ureteroneocystostomy. In presence of augmented bladders, we have to dissect to the native bladder wall before prepare the anastomosis in order to obtain a robust connection to the ureter, avoiding the bladder or the ureter wall that can maybe give more risk of infection and complications. The intraoperative bladder management must face the anatomical exposure in complex cases, and in presence of multiple prior intervention, we can find dense scarring of the tissues in the retropubic and paravesical space. And in presence of small disused bladder, it can be difficult to identify, and sometimes dye injection through the catheter can be necessary to do explorative punction of the bladder and verify the positioning. Donor-recipient mismatch can impair visualization of the bladder in some selected cases. Bladder rupture can be an obstacle, and we have always to check the integrity of the bladder wall before the anastomosis. If rupture occurs, an immediate full-thickness multilayer repair with absorbable suture has to be performed, and in case of a wall integrity severely compromised, a change in the reconstructive plan may be warranted. In our center, we use the classic Lich-Gregoire ureteroneocystostomy that allows a good tension-free anti-reflux and leak-proof anastomosis, minimizing the ureter ischemia. The technique exposes the bladder, and through an extravesical approach via a small detrusor incision, we reach the mucosa through a myotomy, and the spatulated ureter is anastomosed to the bladder mucosa with fine absorbable sutures. Then the detrusor muscle is closed over the implanted ureter, providing the anti-reflux mechanism. In other centers, Some authors prefer the polytanolate method that has some advantages in terms of a more effective anti-reflux protection and allows a direct visualization of the anastomosis from the inside of the bladder to check also possible bleedings. But one of the disadvantages is that this technique is more time-consuming and more technically complex than the extravesical method, and it requires an additional distinct cystostomy that can be a potential source of complications and infection, and the longer ureteric length is necessary, raising the risk of distal ureter ischemia. Some centers have described the ureteral anastomosis that can be end-to-end or end-to-side, depending on the presence of the native kidney. But one of the fundamental in this case is the native ureter must be non-refluent, case not always present in our children. Other complex options can be used, but in selected cases, and complex reconstruction may raise the risk of complications, so they have to be reserved just for selected patients. The ureteral stent placement is another question that can raise in these cases, with pros and cons as always. Some of the advantages is the lower risk of major urological complications, such as stenosis or leakage, and in patients with abnormal bladders, quite frequent in pediatric age, have a higher risk of urological complications, so they may benefit the most from the ureteral stent placement. But the contraindication are the possible complication, especially in migration, stone formation or breakage, and higher risk for BK virus allograft nephropathy, even higher in children because they are not immunized against BK. And the removal of the double J stent is more complicated in children. But as in our experience, an external stent, a brachy tube, early removed after 1 week from the transplantation may be of benefit. So the critical concern is the ureteral ischemia, and the transplanted ureter, being a terminal vessel, derives its sole blood supply from the renal artery from the hilum. So intraoperatively, the risks are the overskeletonization of the ureter, an anastomosis beside the intention, a kinking of the ureter or caused by vessels, and the compression from extrinsic hematoma, lymphocyl, or other complications. And in our children, often heparin therapy raises the risk of hematoma formation. So ensure the an allograft ureter with good color and pulsatility before implantation can be paramount. This attention starts at the procurement, being careful in the dissection of the kidney and of the ureter, respecting the golden triangle of vascularization. But sometimes kidney are prepared in order to check the presence of hematoma or other complications, and skeletonization of the ureter is pushed over the boundaries.
You've seen as the landscape of urological aspects of kidney transplantation, pediatric kidney transplantation is very wide. So there are a couple of questions. So first of all, do primary urological patients differ from the others in terms of results and complication? And then what are the most frequent urological complications and aspects of postoperative treatment in kidney transplant? And then how to prevent and possibly manage them? So you've seen that we are moving in a wide landscape. We can have pre-existing urological condition or transplant-induced urological condition. We can have upper tract complications, which are about the transplanted ureter, the transplanted upper tract, or lower tract, which are about the recipient. Okay, we can have early complication, we can have late complications, and if you want to have a look to the urological causes of end-stage renal disease, you may see as this is a very frequent event, especially in younger children. So this is from US data, and you see as CACUT is the most frequent cause of end-stage renal disease in children below 1 year, and then is still a consistent cause throughout the infancy and adolescence. So there are many urological possible cases of end-stage renal disease. First of all, neurogenic bladder, overt or occult in some ways, and also evolutions of bladder exstrophy, or better, bladder exstrophy treatments. There are LUTO, especially posterior urethral valves, and then other causes like prune belly, urethral atresia, and rarer causes. And then other CACUT, especially if associated with bilateral dysplasia, etc. So there are several studies dealing with this problem. So do patients with the primary urological cause do better or worse than medical patients? The answer is they do in the same way, pretty much. This is a recent report in the Journal of Urology. You can see as the graft survival does not differ in a significant way throughout the years. For sure, patients with the urological cause may have more UTIs in the postoperative period. This is the same concept. This is an older study, and you see like urological group seem to do a little bit better here, probably because they don't have the risk of a recurrence of a medical disease in the transplanted kidney. And there has recently been a systematic review of outcomes in patients with the primary urological cause, and there are very wide ranges of postoperative UTIs. For sure, patients with the lower urinary tract malformation have an increased risk of UTIs. But if we have a look at the urological complications, which are cited in 7 studies in this systematic review, you can see there's a range very wide, also from 5 to 20%, being particularly urethral or urethral stenosis, bladder stones, and hydronephrosis. Now the study here about risk of complication in kidney transplantation, 305 patients, mean age about 11 years. You can see overall they have 3% of urinary fistula or leakage and about 4% of VUR, which seem a little bit in the lower range of the reality if we have a look at our real life data, which we will do in a minute. And also, it was investigated if low weight at transplantation is a significant risk for complication, but you can see that after all, there is an acceptable risk of urological complication and also vascular complication if we consider severe complication, meaning Clavian equal or more than 3. So we will focus now on some urological complications, okay? We will not treat bladder dysfunction, stones, and fluid collection, mainly because there has recently been another webinar about kidney transplantation in posterior urethral valves patients, and it was an excellent webinar, so there's nothing to add about that. We will focus on upper tract complications, so urine leak, obstruction, and reflux. Urine leak usually comes from the anastomosis. It's an early event, but it's possibly also related to distal urethral ischemia. We have seen as the vascularity of terminal ureter is very important in kidney transplantation. So ischemia is a significant risk of urine leak and urine collection. We have also observed, I have to say this is not very common, but high rupture of the calyx or the pelvis in case of distal obstruction, so secondary leak. The main question here is this a risk factor for future stenosis? Probably yes, but we don't have a clean-cut answer. About the treatment, Treatment is usually about improving the drainage, so putting a double J stent if the patient doesn't have a stent, plus the ureteral catheter. In some cases, it's better to use a mono J stent, which has a better drainage. And in some cases, it's required to put a nephrostomy tube. Redo anastomosis is cited as an option, but has not been really done in our series, because we don't believe that redo anastomosis while you have the leak and the urine collection and possibly the infection is a good option. If we come to stenosis, we can have a pure anastomotic stricture, which is usually very low and very short, but we can also have long segment ureteral stenosis, which are usually related to ischemia and necrosis of the ureter. And then we can always have BK virus complication, which can affect the ureter and the upper tract in a specific way. Here we can see some cases. Here on the left side, you see a very early case. This is probably a ureteral necrosis or ischemia, because you see a very long segment of the ureter which is missing. And here on the center and on the right side, you see more distal cases of obstruction. About the management, we can try to use endourology, or we can approach the problem with the redo anastomosis. But we should also always consider the possibility to use the native ureter when the native ureter is free of disease, okay? This may be done as an anastomosis to the ureter, to the pelvis of the graft, or also the anastomosis between the two ureters, so the graft ureter and the native ureter. But for sure, we need to study the native ureter before doing that. Urological treatment is usually reserved to short stenosis, for sure shorter than 2 or 3 centimeters, and the better results are there when the stenosis is shorter than 1 centimeter. 2 main approaches. One is to use the high pressure balloon dilatation under fluoroscopic and possibly endoscopic guidance. The second one is to use the laser incision over a guide wire under direct endoscopic vision. One may ask if the stent duration has really an impact on the outcome, especially middle term and long term outcome. The answer is really, we are not sure, but probably no. There has been recently a systematic review about this, and they included almost 1,000 patients, and they use 2 weeks as a cutoff to define short term and long term. You can see as UTI are similar. Reintervention seem in some ways to be more frequent in the short term, but this is not significant from a statistical standpoint. If you look at stenosis, it looks like they had more stenosis in the short term, but again, this was not significant, and they have significant problems in the assessment of the stenosis. So I will not consider this as a clear evidence. VUR is a frequent finding. We may talk about the VUR in native kidneys and in transplant kidney. We should ask, should we screen asymptomatic patient? Our answer, I think, is mainly no, okay? If they are symptomatic, the first thing to do before doing anything on the reflex is to be sure that the bladder is working in the right way, okay? So to assess and possibly to treat the bladder in terms of capacity and compliance, and then think about the treatment of reflex. There is a high variability of treatments for reflux. This is, again, a survey among several institutions, and you see like most people do urological treatment, but there is no agreement about the best treatment. most of them do endoscopic intervention, but there also is a significant part of urologists and surgeons doing redo ureterocystoneostomy. And if you want to have a look if the reflux has a severe impact on the outcome and the survival of the graft, there has been recently a study published on pediatric nephrology, and the main answer of the study is no. So if patients have high-grade reflux, they have for sure an increased risk of febrile infections, but in the long term, they look similar in terms of graft survival. The main criticism one may do to this study is that they did two groups. The first group included no reflux and low-grade reflux, and the other group included high-grade reflux, but still the evidence, some piece of evidence is here. Finally, it's possible to do a redo cystoneostomy. Yes, it's not very frequent actually. There has been also on this issue a systematic review, including only 78 patients. And it's very curious that the main indication was not obstruction here, but it was reflux. But nevertheless, they had a success rate over 90%. So redo cystostomy can work well if the indication is correct. Just a few words about bladder dysfunction and augmentation. So we know that the conventional approach has been for many years to do a pre-transplant augmentation. It is potentially safer for the transplant in terms of UTIs and pressure. It's something you can plan and program very well if you have a patient who is on chronic dialysis, but there are several drawbacks. The first drawback is that if the patient is anuric before the transplant, you need to do a periodic cycling, which cannot be accepted from all patients, okay? There's a risk of complication. There's a risk of worsening borderline kidney function in some patients, and it may be an overtreatment in some patients. So the newer approach is probably to consider in several cases to do the augmentation after the transplantation. You can have better patient selection, you avoid overtreatment, you don't need recycling, but the main drawback is that in many patients, you need a temporary diversion to ensure that the kidney is functioning well while they wait for the procedure. This is our historical cohort of kidney transplant in the augmented bladder, and you can see as they seem to do well as non-augmented bladders. So the augmentation before kidney transplant is safe, or it was safe in our historical cohort, but there has been a recent study also here comparing approaches, so comparing the pre-transplant and the post-transplant augmentation, and it doesn't look there's really a difference in terms of major events, including graft loss and UTI-free survival. Just a case. This is an open case. We don't have an answer. We can discuss it further. This is a male, a 13-year-old male, who had a prenatal megabladder. He underwent vesicoamniotic shunt and then bilateral ureterostomies at birth. And then he received, 4 years later, he received a kidney transplant from a living donor with a cutaneous stoma. And he has had the cutaneous stoma for 10 years. So now he's 13 and he wants a treatment. So I would be happy to hear your opinions on this case.
Good afternoon, everyone. I will focus on our research about urological complication in pediatric kidney transplantation. As we know, data about urological complication in pediatric kidney transplant are very limited compared to adult population. Therefore, the aim of our study is to provide clarifications of these issues by defining the incidence, diagnosis methods, and management strategies of such complications, identifying potential risk factor and establishing a clinical and instrumental approach for an early recognition and treatment. We retrospectively analyzed 178 pediatric kidney transplant recipients at our center. We included all patients under 21 years and with the diagnosis of post-transplant urological complication. We excluded very early technical complication occurring within the first days after transplantation and fluid collection that did not require intervention. We collected clinical and demographic characteristics of our population, diagnostic workup, and BK virus status. And according to time of occurrence, these complications were divided into early, occurring between 7 and 30 days after transplantation, intermediate between 1 and 3 months after transplantation, and late, occurring more than 3 months after transplantation. Among 178 patients, pediatric kidney transplant recipients at our center between 2011 and 2023, 28, corresponding to an overall incidence of about 16%, developed urological complication. The most common was urothelial stenosis or obstruction, followed by symptomatic vesicoureteral reflux and obstructive perirenal collections. While comparing characteristics of our population with urological post-transplant complications to patient group, control group without urological complication, we found no significant differences in terms of gender, age, donor type, cause of end-stage renal disease, previous renal replacement therapy, and number of transplantation. And the mean follow-up was more than 5 years. This table shows the most common complications and shows the type of the complication, the timing of occurrence from transplantation, the diagnostic pathways, and approach, endoscopic or surgical. Urethral strictures appear to be the most common urological complications with a median onset at 2 months. And they clinically presented usually with acute kidney injuries and evidence of hydronephrosis and abdominal ultrasound. The majority of these patients underwent endoscopic treatment with urethral stent placement, but more than half of this population require a definitive surgical correction. The second most frequent complication was symptomatic vesicoureteral reflux with a median onset of 2 years after transplantation. These patients presented with urinary tract infection, and almost all patients underwent endoscopic defluxination with a high success rate after deflux injection, and surgical correction was reserved all to patients with recurrent urinary tract infection. Then we looked at potential protective and risk factor for urological complication, and we found two protective factors: having a living donor transplant and having undergone dialysis before transplantation. Regarding the first factor, it can be explained by the reduced ischemia time, the best knowledge of the donor, and the best operative models, and these results are in line with other literature studies. The second factor, dialysis before transplantation, is in contrast with the literature, but can be justified by a shorter duration of dialysis in children, or by the implementation during dialysis period of strategies to optimize bladder function. But we found no association with the sex, age, cause of end-stage renal disease, number of transplant, and prior abdominal surgery. Regarding survival, overall survival, both of the children, of the patient, and graft survival, we found no differences between patients with and without urological complications, suggesting that such complications do not impact long-term graft outcome. But on the other hand, they increase significantly healthcare costs and the number of hospital admission of these patients.
Okay, thank you for your attention. We are open to take any question. So we have one question that has been written. Okay, it says, thank you. Okay, is there a volume cutoff to predict success into the functionalized small capacity bladders? So this is a difficult question, actually, because I think the main thing is that it depends on the overall pathology, overall disease, because there are some diseases where you can start from a very small bladder and then reach a good volume and good compliance, while in other cases you cannot do that. So I don't think there's a clean cut answer in terms of cutoff. I think it is more related to the age of the child and to the disease.
To the time of anuria, probably.
And also the time the child has been anuric, another factor.
Yeah. We have another question.
This is a medical question. So your experience with for graft versus host disease in pediatric kidney transplantation? Graft versus host, you mean rejection probably? Or
Yes, that person says yes.
Graft versus host disease isn't a clinical complication after solid organ transplantation.
If rejection.
so you want to give a short answer about rejection?
Rejection.
Yes, probably a rejection.
Yeah.
Yeah.
Okay.
So probably. Lui dice yes, quindi vuole sapere del rejection.
How's your experience?
In
In terms of number, in terms of frequency, in terms of
About
it's a very
rejection.
huge concept.
About rejection, our patients underwent independently of renal function, protocol kidney biopsy at 6, 12, and 24 months after transplantation. And this approach provides the possibility to screen subclinic rejection that in our experience could be treated to improve graft outcome.
Okay, there's one more question. How do you select patient for augmentation pre or post? I mean, here it depends again on the disease, okay? But it also depends on non-urological factors. For example, one key factor is whether or not the patient is eligible for preemptive transplantation and or from living donor, okay? In this case, if we are sure that the patient will need an augmentation or a diversion, we can plan it and then plan the transplantation afterwards, okay? If we have patients on chronic dialysis, which are on the waiting list for a deceased donor, in this moment, we are not doing augmentation or preparation before, because we think that having a patient that need to do their recycling for years is not a good thing for the function of the reservoir. So in this case, I would prefer the modern approach and to do the post-transplant augmentation or preparation. How long do you create the leachable graft? It's for you.
Actually, we created channel in normal or quite normal bladders about 2 centimeters, more or less. We try to keep this length.
Great, thank you. So at least a couple of questions came in at the end eventually. I think that is about it. Just going to give people a little bit more time if they want to ask one last burning question. And I am thanking you both for being here, for doing the pre-recording. And as I mentioned, the link for the recording will be sent tomorrow via email to everyone who registered. And please fill in the post-webinar survey, because you will also help us continuously improve our sessions. Okay, so no more questions came in. Thank you all to the attendees who joined this webinar. We will have another one next week on Wednesday at the usual time. And thank you to the presenters for being here for the very interesting presentations.
Thank you very much.
Thank you.
Thank you for the opportunity.
Thank you.
Ciao, ciao.
Bye-bye.
Bye-bye.
Bye.